Squamous cell carcinoma of the mouth is not one disease. It's a family of diseases. If we use etiology, clinical presentation, and clinical behavior, squamous cell carcinoma of the mouth comprises at least two major diseases. The two major types are tobacco oral squamous cell carcinoma affecting the anterior mouth and HPV oropharyngeal squamous cell carcinoma affecting posterior mouth or the throat. It is important to distinguish between these two entities.
For dental offices, it's really important to engage your entire team. They need to understand the link between HPV infection and oropharyngeal cancers. They also need to understand that the vaccine is safe and effective. The other thing they need to understand that the best time to get vaccinated is to finish the series before age 13, and that giving a strong message focused on cancer prevention is much easier and simpler than getting into an awkward discussion about sex.
Hello there, my name is Stuart Lyman, and I'm speaking to you today because I am an HPV oral cancer survivor. I live in Seattle, Washington, and I'm making this video because I want to alert people to the dangers of the 6 different types of cancer that are caused by HPV, and because these cancers are actually preventable, there's a vaccine that will prevent the vast majority of these 6 different types of cancer. And I know a lot about cancer because, in fact, I spent most of my career as a cancer researcher. I have a PhD in cancer research, and I can tell you that being a cancer researcher is a heck of a lot more enjoyable than being a cancer patient. Oropharyngeal cancer is the most prevalent of the 6 types of cancer that are caused by human papilloma viruses. Each year in the US, there are approximately 14,000 people who are diagnosed with HPV-caused oropharyngeal cancer. And that group is comprised of both men and women, but the incidence is not shared equally. There are about 5 men for every woman that is diagnosed with HPV-caused oropharyngeal cancer. The incidence of HPV-caused oropharyngeal cancers has been increasing for decades. Over the past 30 years or so, the incidence has actually increased. It's up 225%. So it's becoming an increasingly prevalent problem that people need to learn more about, and that people need to be aware of the signs of oropharyngeal cancer so they can go see their doctors. As with most types of cancer, it's always important if you can diagnose oropharyngeal cancers at the earliest stage possible, because at that stage they are much more treatable and are curable.
The tobacco-related squamous cell carcinoma patient is usually a male around 60 years of age, and it's more common in Hispanics and Blacks, and is usually a heavy smoker, which is defined by 20 cigarettes a day for 20 years or more. And some of them are also heavy drinkers. Compared to the HPV oral squamous cell carcinoma, the patient is usually white male, 30 to 40 years of age, never smoked or rarely smoked, and drinks, which is usually in a moderate amount. And the clinical presentation that you see here is the typical presentation for squamous cell carcinoma tobacco-induced, which presents usually in mixed red and white lesions or non-healing ulcers or combination of mixed red and white and non-healing ulcers. And the most common site is going to be ventral lateral tongue and floor of mouth. And that's the typical presentation for tobacco cancer. While the typical presentation for oropharyngeal cancer is a lump in the neck. And the lump in the neck can be tender or not. And it's usually present there for more than 2 weeks. The tobacco has poor prognosis, while the HPV has good prognosis. Tobacco is anterior mouth, which is very visible. You can see the presentation, any of the signs and symptoms, while the posterior mouth is very difficult to see. And as I mentioned earlier, one of the major presentations for oropharyngeal is a lump in the neck. So as much as tobacco is discovered early, but it has worse prognosis, while the HPV is discovered late and has better prognosis. And with HPV, the disease can be very small, sometimes not even visible. So endoscopy may help most of the times, but sometimes the disease is not even discovered through that process.
Well, this is a great opportunity for the dental community to partner with the medical community to increase the rates of HPV vaccine for our children. We know that kids often see their dentist many more times than they see their pediatrician or their medical provider. In fact, dentists may see a child 2 times a year, where a pediatrician might not see them for several years until it's required for school or sports. And I think if the dental community feels comfortable about knowing about HPV vaccination as a powerful cancer prevention tool, they can help promote the HPV vaccine. I think some of the simple things that dentists could do is they could hang an informational poster in the waiting room that describes the link between HPV infection and HPV-related oropharyngeal cancer, and then the importance of the HPV vaccine. I think that dentists also need to know that the best time to start the vaccine is between ages 9 to 12, and the best time to finish it is before age 13. And also dentists need to know how to be comfortable with giving a strong recommendation for HPV vaccine. It could be as simple as, we think the HPV vaccine is really important for cancer prevention, and we think your child should get that vaccine. Dentists should also know who in their community can provide the HPV vaccine, such as a medical provider, public health clinic, or school clinic. And one other thing I was thinking about is that dentists could have a simple question about the HPV vaccine on their medical history form to find out if the patients have received the vaccine, and if they haven't, this would be an opportunity to start the discussion. HPV vaccine is powerful cancer prevention. We're making progress, but we really need your help. The dental community is going to be key to getting our population vaccinated, and we want to get everyone vaccinated before they're 13 to have the most beneficial effect in preventing HPV-related cancers, specifically oropharyngeal cancer.
Human papillomavirus HPV. There are more than 200 different known strains of the human papillomavirus. Research has linked 9 different HPV strains to various types of cancers. Studies can demonstrate infections with the human papillomavirus, specifically HPV-16 and HPV-18, as being a significant risk factor for oropharyngeal cancers, OPC. It is also believed the latency period for HPV-16 and 18 that cause OPC can be as long as 40 years. In recent years, HPV-related oropharyngeal cancers of the tonsil and the base of the tongue have become increasingly common. In 2019, 1 person died every hour, every day in the U.S. from HPV-related oropharyngeal cancer. Predictions forecast this number is still on the rise. Sexual activity, including oral sex with someone who carries the HP virus, is the most likely route of transmission. Limiting the number of sexual partners can significantly reduce the risk of HPV exposure and infection. but combined with pre-adolescent completion of the HPV vaccination is the most effective way to stem HPV cancers. Receiving an HPV vaccination before exposure to the HP virus can effectively reduce the risk of oropharyngeal cancers. The Centers for Disease Control and Prevention recommend the HPV vaccination be given to all preteen boys and girls prior to the commencement of sexual activity. Early studies have shown the vaccination is also extremely effective against HPV-6 and HPV-11, which cause genital warts, indicating strong evidence it's equally effective against HPV-16 and 18. The motivation for this video comes from the inability of dentists to effectively and consistently make an early OPC diagnosis. For the most part, dentists do not have endoscopes to view down the pharynx for lesions. Interestingly, if oncologists are asked how they would start an oral exam for cancer, looking in the mouth would not be their first point of action. If dentists are being asked, they would start with a visual oral inspection. Why the different approach? Oncologists agree that should lesions be detected in the pharyngeal area, the patient is probably already at stage 3 or 4. Therefore, it's imperative that diagnosis occur earlier before lesions appear. But how do we do this? Dentists can ask a series of questions before starting or during the oral cancer screening to help determine if a potential ENT referral is necessary. There are 11 critical questions that can be asked. 1. Do you have any white or red patches on your tongue or tonsils that have been there over 2 weeks? 2. Do you have excessive phlegm buildup, or are you consistently clearing your throat? 3. Do you have persistent coughing? 4. Have you noticed your voice changing? Have you had bouts of hoarseness? 5. Do you have a persistent sore throat or feeling that something is caught in your throat? 6. Do you have difficulty swallowing or chewing? 7. Do you have difficulty moving the jaw or tongue? 8. Do you have numbness of the tongue or other areas of the mouth? 9. Do you have a lump in the neck? It need not be tender or painful. 10. Are your cervical lymph glands sore or tender? Dentists will also routinely palpate these glands. And 11. Do you have unexplained weight loss or persistent bad breath? It's important to remember that a yes answer to any of the aforementioned questions is not a diagnosis of OPC. These are all common symptoms of many temporary afflictions and in and of themselves don't constitute a diagnosis. If suspicious, a referral should be made for follow-up with an ENT. Remember, a delay in referral means a delay in diagnosis and treatment. Now, on to the oral cancer examination. In this video, we hope to demonstrate one example of how to do a complete oral cancer examination, including asking important key questions for oropharyngeal cancer detection. By performing the exam in real time, hopefully it'll show how easily OPC can be incorporated into any oral cancer examination. The goal is for dentists to do an oral cancer examination on all patients at all visits. When performing the exam, verbally educate all patients about the importance of oral cancer screenings, emphasizing how important early detection is. Discuss risk factors, tobacco, alcohol, e-cigarettes, hookahs, etc. Also, a discussion about the HPV vaccine, especially if they have children as a tool for cancer prevention. Finally, don't forget to ask the OPC 11 questions during your exam. Oral cancer screening. Performing a complete oral screening regularly during every exam can be the first step to early detection of oral cancers. Dentists can dedicate a few minutes thoroughly conducting an extraoral and intraoral exam and potentially save a patient's life. But how does one perform a comprehensive screening? This video will outline and illustrate each and every step. Step 1, the extraoral exam. We'll start off with an extraoral exam, focusing on the lymph nodes around the head and neck. Before any palpation, the dentist should thoroughly examine the head and neck for any asymmetries, as well as observe the vermilion border of the lip, the hairline, and scalp for lumps, abnormalities, or ulcerations. Many throat cancers demonstrate asymmetry around the cervical lymph nodes. Next, the dentist should palpate underneath the chin for submental and submandibular nodes, feeling for any lumps or irregularities. Here, the dentist can also ask the patient to swallow while palpating the neck and thyroid to check for any irregularities. The dentist can ask the patient to turn their head to the left and to the right to check the lymph nodes in the anterior and posterior cervical triangles near the sternocleidomastoid muscle. The dentist should also palpate the occipital nodes at the base of the head and continue to the retro and preauricular nodes. As the dentist approaches the TMJ, they can ask the patient to open and close, noticing any irregularities with the joint. Lastly, dentists should also check the supraclavicular nodes. If all appears normal, the extraoral exam is complete. Step 2. Intraoral exam. Donning fresh gloves, the dentist can now begin the intraoral exam. Here the dentist can begin by observing the gingiva for abnormalities in color, texture, or growths. Next, examine the labial and buccal mucosa for uniformity in color and texture, running a finger over the cheeks and depth of the vestibule. Once this is completed, the dentist can observe the hard and soft palates. The dentist should ask the patient to stick their tongue out, where a careful check of the lateral borders of the tongue can be done. Are there any visual abnormalities in color or texture? Are there any abnormalities to palpation, such as lumps or nodes? If so, are they over 2 weeks in duration? The dentist should also pay attention to the anterior and posterior pillars, the palatine tonsils, and the posterior pharyngeal wall. Next, the patient should put their tongue on the roof of the mouth so the dentist can observe the floor of the mouth. The dentist should palpate the sublingual glands, pushing down on the floor of the mouth while simultaneously palpating the area extraorally, two-hand palpation of the floor of the mouth. If all appears normal, the intraoral exam is now complete. Conclusion. It is important to be vigilant advocates for our patients' health. Though it may seem like a time-consuming process, a thorough oral cancer screening could potentially save a patient's life. Oftentimes, the detection of a positive node during an extraoral exam may be the only clinical sign of oral cancer.